Well, I have the honor to introduce the next speaker to you guys. Huh? Nobody's going to introduce me, so I have to introduce myself. Um, I'm very thankful to the selection committee to allow us to present these early results from our long-term study on survivorship, which ECDGA is an integral part of and a collaborator on. So these are very preliminary results, but I think it's good to just take a look at what kind of questions you can ask using this resource. So this is our study team here. I'm not going to belabor this point that targeted therapies work. But really, from my point, my training is now in health services and survivorship. But I think this is as a model, a classic model, ECD or histiocytosis as a classic model for survivorship research. Because you have people who are living longer from the disease, so they have a higher risk of health problems down the road. So what we see and celebrate, when 5 years ago at least, we were very excited that we get high response rates, this biology is cool, we can target it, and we think that disease is in control for a long time, but we all agree, and we heard yesterday, that patients continue to live with the exposure to treatment. Organ dysfunction or late effects are possible with any treatment. I don't believe anybody who says there is no late effects that happen with anti-cancer treatment. And of course, symptom burden has been shown by many of us in this room. Healthcare needs, and including second cancers and second health conditions. So tumor response alone, of course, can underdescribe long-term the burden that is experienced by the patient. So in fall of 22, we launched this very ambitious study to understand long-term outcomes in patients with all histiocytic disorders. So you can see the 4 domains with the burden of morbidity, starting from chronic health conditions, then going to psychological outcomes, pain, and health-related quality of life. We're also going to look at healthcare utilization in various domains, burden of mortality, including cause-specific mortality, and ultimately what my dream is, or my hope is, that we'll be able to do targeted interventions, identify high-risk subgroups who are at the risk of complications of various types in the future. So this study is in partnership with ECDGA and Histiocytosis Association. So we have a partnership where we then reach out in collaboration with the organizations to the members. There's a multimodal outreach, and Caroline here can attest to how many calls we make every day. And then participants receive a survey that asks them about their health problems, their symptoms, various patient-reported outcomes. We then also obtain their medical records for validation of diagnosis, health conditions, and so forth. And then this goes into quantification of how severe is a health condition. And this is based on CTCAE guidelines, that CTCAE criteria that are already in place for survivorship research. We use them in clinical trials all the time, with grade 1 being mild, grade 2 being moderate, 3 being severe, 4 being life-threatening or disabling. For this particular analysis, we were focusing on prevalent chronic health conditions at the last follow-up, and also incident, meaning new onset health conditions after the diagnosis of ECD specifically. And we excluded any health conditions that occurred within the year of the diagnosis, so that we are not assigning them wrongfully to a pre-existing condition. So this is not novel. The research methodology itself is not novel. What's novel is that we are partnering with the organizations. But this is well studied in childhood cancer survivors and blood and bone marrow transplant survivor study, who Dr. Bhatia, who was my mentor in building this cohort. And they have helped shape the guidelines on how we follow up these patients strategically and in targeted interventions to prevent late effects. So we have close to, I would say, we had 900 surveys completed with all histiocytosis. Then we cut down, focused only on ECD, and then we excluded some patients which didn't have enough dates or didn't have enough follow-up. We haven't completed the full survey, or the follow-up date was not there yet. So we still have to keep reminding participants to complete part of the survey at time. But at the end, we had 126 completed surveys that data were included for this particular analysis of health conditions, out of which 111 were alive and 15 were deceased. This is the table. It may seem pretty busy, but just to give you an idea, we're all used to seeing these organ manifestations graphic, but you can see on the right. And then you can see the follow-up since diagnosis is 5 years with the range 2 to 9. Still not very, very long follow-up, so which we are hoping to achieve, but still enough to get post-acute phase health conditions captured. Median age, 54, male predominant, and then we had, of course, racially, this is still a disease that affects the white population more, but we had some other races represented and some Hispanic ethnicity participants there. 60% had of those with BRAF mutation data had the BRAF V600E mutation. So this slide really captures our primary endpoint for this analysis. So the graph, the bar chart in orange, first of all, the two things. So first is any grade health condition, meaning any health condition, mild to severe. The other is just focusing on the severe, which is really the main endpoint of interest for these studies. But the orange bar is telling you what conditions were prevalent, meaning present, and green ones are what are new conditions that happened after the diagnosis of ECD. So as you can see, about 79% participants had at least one grade 1 to 4 health condition at last follow-up, and 70% developed new onset health conditions after the diagnosis of ECD and at last follow-up. Now, this excludes the 1-year period after ECD diagnosis. Now, even more important is the severe grade 3 to 4 health conditions. A third of the patients had new onset grade 3 or 4 health conditions, and 40%, of course, had prevalent health conditions. This data also allows you to further dive deeper. You start from a broad lens and you keep going deeper and deeper. So when you try to look at what are the health conditions that developed newly, and that includes ranges from, you can see vision problems, neurological dysfunction, second cancers, endocrinopathies, hearing problems, renal dysfunction, cardiovascular problems, GI, musculoskeletal, and least was respiratory out of these symptoms. Now, eventually, of course, we want to be able to go further deeper into it and figure out, what cardiac health problem is MI versus hypertension versus cerebrovascular disease or so forth. But this is the first snapshot we have from this study. I did want to go into a little bit about the second cancers because that's of interest to several folks and can affect prognosis. The most important one, as you would imagine, is the cutaneous squamous cell cancer that also is seen in other lymphoid and myeloid malignancies pretty commonly and may have to do with the treatment effect as well. But we did see other cancers such as prostate cancer, CMML, breast cancer, renal cancer, and one other unspecified carcinoma. I did include LCH in here, one case of, later on diagnosed as LCH, although one could argue that's not really a second primary cancer, but for the method, for a purist standpoint, I just included in this analysis. Of course, there are limitations to doing such a study. It's a retrospective cohort. Ideally, you want to follow these people prospectively. Our plan down the road is to do a subsequent survey at 5-year mark for each of the individuals so we can get longitudinal follow-up. There's also concern about recall bias in any of these situations because we are asking participants to remember things from the past. So for that, the standardized way to handle, which is very labor-intensive, is to get their medical records and validate everything, which takes the most time, and that's why we have a lab and personnel to help with it. Of course, there is participation bias. Initially, the people who participate in any of these studies are the people who are more eager, who are maybe not physically unwell, but may have more anxiety, and people who are more available, have technological access and know-how. But that is why this study needs more ongoing enrollment, and eventually we want to compare it to other cohorts to see if it is representative of the other populations. The other thing that this study allows is to enroll next of kin for participants who are deceased. And so that is why we are able to capture what were the health problems of the participants who passed away 2 years before they passed away. What were they dealing with? What were their treatments? And of course, aggressive outreach is very important. Our target, it's about 300 epidemiologically or health services why we were talking earlier, you actually need something somewhere between 500 to 1,000 to actually do risk stratification of subgroups and molecular and other risk factors and run a regression model. But for this study, even if you want to do estimation, you need at least 300 participants. So we are nearly halfway, I would say, there. And then, of course, ongoing validation of medical records, that always lags behind. It takes time to do that. A lot of work goes in that. And then, as in epidemiology, it's not enough to say, well, X% of people have health conditions. So what about this same population, same age, sex, and race, matched population without histiocytosis? Would they have the same health conditions? Because it's also an aging population. So we are also starting to recruit a control cohort to do this systematically. So this will take a few years to execute the results, the first primary result publication. And then eventually we can do risk stratification and also look at the exposures, including treatments, targeted and non-targeted. And of course, intended outputs will be in collaboration with the ECDGA and patient support organizations. And we already have patient partners on this study that are guiding us on dissemination and how to frame our outputs. But eventually, we hope to have those survivorship recommendations out, like the questions Dr. Abekun was posing, how long to follow people for, what to look for. We all see these second cancers. Are there people who are at more risk of second cancer? Are there people we should be doing bone marrows more? Are there people, with clonal hematopoiesis and so forth that we can dive deeper and deeper into and then lead to interventions to reduce late effects? So it's a long-term project. But I'm very appreciative of the ability to present these results to you. So in conclusions, we can say, at least from these prelim results, that the ECD survivors experience a high burden of chronic health conditions, including new onset health conditions, morbidities. So they already it's an older population. They are already starting with a higher burden of health conditions. And then on top of that, they're developing new health conditions that eventually we will have to contend with and try to figure out how to prevent them or prevent them from progressing. And then cohort expansion is critical, and linkage to treatment exposures to further fine-tune what are the subgroups that are at high risk, so you can do tailored survivorship screening and other interventions. It does take a village to do a study like this. We have Caroline is here, but we have several other members who have worked with the lab. And so I'm very grateful to my collaborators, my team, patients, and families, of course, who participate eagerly in all these long surveys and our follow-up calls. I'm very thankful to ECD Global Alliance, who have been, I don't know if Renita is in here, or not Renita, Belinda is in here, but Belinda and Kathy have been really, really supportive, and they are working tirelessly. They're even calling patients on our behalf, and I'm very grateful, and they also funded part of this study. So thank you all for your attention. I will take some questions now.